3, 2, 1, go.
It's an honor to welcome all of you to this webinar of the Academic Wing of Assisted Reproduction, Trichy, Tanjavur, Tiruvarur. We are having an ongoing program every month, and we are extremely honored to have a great speaker, Dr. Chinmayi Ratha. And whenever you listen to her, you'll know the clarity of her thought. And we thought it's necessary for our members to understand that only conception is not the end point of our assisted reproductive procedure. You have to take the mother through pregnancy, and usually has so many of challenges, and you'll never know when the challenge is thrown at you. And it's also a great medical legal point if the baby is not looked after well during an ART pregnancy. And that's why we have to know like how to manage a ART pregnancy. So it's my honor to welcome the speaker, Dr. Chinmayi Ratha, eminent fetal medicine specialist, and may request our treasurer, Dr. Manjula Appathurai, to welcome the speaker.
Good evening. Today's topic is unique challenges in fetal care of ART pregnancies. Dr. Chinmayi Ratha, MS, FRCOG, FICOG, Diploma in Fetal Medicine. She is the Director and Lead Consultant, Resolution Center of Fetal Medicine, Hyderabad, Senior Consultant, Fetal Medicine and Gynecologist, KIMS Sunshine Hospital, Hyderabad, Visiting Consultant, Fetal Medicine, Arita Hospitals, Hyderabad. She is the Center Head, ICOG FM Certificate Course, FMF Approved Examiner, MRCOG Part 3 Examiner, and a peer reviewer of Jogi JOFM. She's won so many awards. Dr. Mehru Dara Consortia Award for
It's
Best
okay, Manjula. Let's.
Parent Oration Award, CS Dawn Prize Award, Kamal Bakshi Award, Shirodkar Memorial Oration Awards, Foxy Young Youth Author Award, and so many awards to her credit. I welcome you, Dr. Chinmayi.
Thank you.
Thank you.
Thank you so much, Manjula. And thank you, Charmila ma'am, for this opportunity. And it's indeed a very, very unique topic that you've given me. And this the thought process behind this topic tells us how much people who do ART or who help the couples conceive after a lot of difficulty, how much they think about the end point of care. Like Charmila ma'am just said, getting somebody pregnant is just the beginning of the journey. So beyond that comes all the challenges. So we all have heard of Louise Joy Brown, and we remember her very fondly as the first ever child born by IVF. And when we watched that recent movie, Joy, we saw with how much difficulty the whole science of IVF was put into place, the whole practice of helping couples conceive who were otherwise not being able to conceive, how that whole thing started. But from 1978 to 2025, there has been a paradigm change. I mean, in those days, to do that one IVF, people struggled so much. But today we know that there are so many centers which offer IVF, and within IVF also, the entire gamut of technology has changed. We have reached next generation genetics in ART pregnancies, and we are somewhere very much at the brink of what we can call as cutting edge technology. So in 1978, achieving that successful pregnancy was the success of artificial reproduction. But then from there to now, what we have understood is that just the pregnancy is not enough. It has to be a take-home baby rate. And again, the baby that you take home has to survive, but not only survival, intact survival is important. Congenital anomalies may be part of it. There is a debate whether it really increases in ART pregnancies or not, but there are literature, reports to suggest that some degree of escalation in rate of congenital anomalies occurs in pregnancies that are conceived with ART. Chromosomal and genetic issues may be more in that population, and multifetal pregnancies happen, and therefore challenges related to multifetal pregnancy. So every pregnancy is precious. We've heard this again and again and again, that every pregnancy is precious. So what is a precious pregnancy? We don't like the word precious pregnancy. We must have heard it several times from our teachers also, that every pregnancy is precious. But then when you think of a pregnancy, we treat it with a lot of respect. Being obstetricians, we want everything going well for the mother. But the moment we come to know that she has also conceived after artificial reproduction, within that precious, this becomes a super precious, just like so many precious stones are there, but when you see one rare gem there, something special happens. So that is how we all know that pregnancies conceived with artificial reproduction definitely demand a little extra care, a little extra. We can't define it. There is no quantification of that care. There is no quantification of that preciousness. But I'm sure all of us who are clinicians understand what I'm saying, that there is that little extra expected in a pregnancy that has come after artificial reproduction. The general challenges with ART pregnancies are multifaceted, and we will take case by case different scenarios which will pick your brains and give you the idea what I'm trying to express. So this is Mrs. X. She is 40-year-old. She's conceived through IVF and she comes with an increased risk on the double marker. Now, you see, as soon as the pregnancy test was positive, this 40-year-old lady must have gone through so many challenges before she actually became pregnant. So, when her pregnancy test must have come positive, that must be a day of extreme joy and happiness for her and her IVF consultant. But like I said, the pregnancy is just the beginning of the story. And then she went to the first trimester. She had a scan, which was kind of normal, but then she was offered a biochemical screen. And after that, her risk for Down syndrome has come as 1 in 80. Now she's scared. She's very scared because the cutoff on that report says 1 in 300 and her risk is 1 in 80. Anything more than 1 in 100 by all standards comes in the category of high risk. So what should we now suggest for her? Should we suggest a quadruple test? Should we suggest an NIPT or should we suggest an amniocentesis? There are, multiple choices available here. But again, she's 40-year-old. Any invasive test carries a risk of miscarriage. And then we go on thinking of everything and getting worried and making her worried. And we all know stress itself is a bad prognostic factor for pregnancy. So how do we reassure such patients? Anybody can have a high risk on a screening test, but when it is a 40-year-old woman after IVF, all of us understand that there is something, all of us are sitting at the edge of the chair and we are a little more worried. We want to alleviate her anxiety and we want to, plan care in a way that things will be better. A lot of explaining, a lot of listening, a lot of talking is involved. But before talking, we have to know our facts. What do we have to tell this lady exactly? First of all, was it her own eggs or was it donor eggs? Did we ask this question? No. Now I'm asking that question. So once I ask that question, she tells me that, it was a donor egg. And if it was a donor egg, then the age of the donor was not 40 years. All of us know that even if IVF centers don't necessarily tell us the age of the donor, they never take donors more than 27 years. So you can take 27 as a random cutoff if you don't know the age of the donor. Ideally, you should, but if you do not know, take a random cutoff of 27 years. And the moment you do that, the baseline risk will shift. So that 1 in 80 came because we used her own age of 1 in 40 as the baseline risk. But once we have used the donor age of 1 in 27, the risk becomes very low. And then you can actually reassure her, you actually do not even need to do anything more than that. For those who understand screening better, I may reiterate that 1 in 80 is actually not bad for a woman who's 40 years old, because at 40, her baseline risk would be higher, and 1 in 80 is somewhat a reduction, even with a bad biochemistry. Now, in IVF pregnancies, the PAPA values are usually a little low. So in Down syndrome, we expect low PAPA, and therefore, whenever PAPA is low, the risk for Down syndrome will be high. So in IVF pregnancies or ART pregnancies, there is a very high chance of having high risk on the biochemical screening, which does not always translate into a abnormal fetus per se, but it gives a screening false positive. And therefore, there are challenges with how to take it forward, but you definitely do not want to do an unnecessary invasive in an IVF pregnancy. And that's where the uniqueness of taking care. And any other case, we would have not hesitated in offering her an invasive test. But in a 40-year-old woman who's conceived with IVF, even as a clinician, you think and decide when an invasive test can be avoided if it is unnecessary. So here what was required is the source of the egg, the age of the age of the ovum donor, and that is usually less than 27. And once you do that, automatic correction happens and the risks are not that high, and therefore we can just reassure her. A 38-year-old woman comes for a TIFA scan. She's a primigravida, again with IVF conception, and she has conceived dichorionic diamniotic twins. Prior to this, she's had 2 failed IVF pregnancies. So now you tell me, are you all comfortable, or are you thinking little differently than others? How much ever we say every pregnancy is precious, this becomes like a precious, super precious pregnancy. We will not do unnecessary things, but at the same time, we will have to take a decision a little different from what we would do in any other pregnancy, because her focus is different, her background risk is different, her entire scenario is different. She's missed her double marker screening, and now she comes for the TIFA scan. When you do the scan, you see that one of the fetuses has a hypoplastic nasal bone. Now, what do we do? NIPT or amniocentesis? Ideally, an amniocentesis is the test of choice for somebody having hypoplastic nasal bone. But can you just test one fetus? No. Whenever you do twin pregnancies, the guideline says if you test both of them. Now, if you test both of them, you have a higher risk of miscarriage as compared to singletons. And she is 38 years and she's had 2 failed IVF. She somehow got pregnant this time. She just doesn't want a risk of miscarriage. So you go on and have that counseling, like I said, explaining, listening, counseling, back and forth, back and forth, back and forth. What she decided was, okay, doctor, what is it that you are really worried about? You're really worried about Down syndrome. Let's rule out that by an NIPT. If that comes normal, I don't want any amniocentesis, because I will deal with whatever it is after birth. Dr. Charmila just said there could be medico-legal implications. And yes, there could be medico-legal implications, because a hypoplastic nasal bone can be a marker for so many things. But look at the parent. They are saying that we are not concerned about many things because now so much anxiety has been created. We are okay with doing an NIPT so that we are only aware, but we are not going to do an amniocentesis. So this decision has been taken in a unique manner, considering the merits of this case with full documentation and full consent of the parents, so that they understand that what they have done is a screening test. It's good news that the screening test has come low risk. How does NIPT work? The NIPT works as good as singletons in twins for Down syndrome. That much we know. The ACOG practice bulletin has clearly told us that. If the NIPT is low risk, that means both the babies are unlikely to have trisomy 21 or any of the major aneuploidies or any of those major stuff for which we check the NIPT. But if it comes abnormal, that means at least one of them may be having some abnormality, or it may be placental mosaicism. So you avoid testing anyone if the report is normal. If the report is abnormal, you may offer amniocentesis for both, but the chance that you will find a positive result is much more than that. So that is how we use it in twins. Now, this couple did not want anything. So one can argue theoretically, then why did you test at all? You could have just left them alone. But in real life, 2 plus 2 is not always equal to 4. Sometimes they want little clarity. They don't want a complete clarity. They also want to take their decision later on. So they would be okay with seeing the NIPT, even if it is high risk. They may not decide to test, but they want some clarity. So you understand what I'm trying to tell them. Give them full information, explain the pros and cons of every test. Now, we were lucky here that it came as low risk. I have had cases where we have done amnios also and found Down syndrome and still continued the same way, because they got scared and they said, we are not going to do any reduction. So later on, when we discussed the case, we also thought, why did we do the amnio in the first place? Because they were not going to change their decision. But human beings are like that. They change their decision. People withdraw consent after some time. At any stage, the clinician's responsibility is to give full information and do whatever is correct for that clinical situation, having given the center point to the patient. The patient makes the decision. Yes, the patient is not as educated as you are, patient is not as aware as you are, but for his own situation, he is the best judge. So our role as clinicians is just to give them complete information. So there is no right or wrong. Is NIPT enough for hypoplastic nasal bone? In an ideal situation, no. I would like to do a cytogenetic microarray, look for microdeletions, duplications. But in this particular pregnancy, in a woman who's 38 years, who's had 2 failed IVFs, conceived with an IVF, and she is not very keen, what will go wrong? If at all the baby has some kind of microdeletion or something which is discovered after birth, she's ready for it. She's already said that, look, I don't want an amniocentesis, and I am not going to, worry if the baby has a problem later on. At least that's what she said now. So I document that decision and move on. There is really no right or wrong here. This is a unique challenge. Whenever we plan care in pregnancy, there are different perspectives. Depending on how you look at it, you may interpret it differently. But what happens is, as fetal medicine specialists, as obstetricians, we get very carried away, and we think this is the way it has to be done. This is what is perfect, and she should do this. But it may not be what she wants. And that is where we forget it, that it's not our pregnancy, it's their pregnancy. Even if you have got her pregnant with that IVF, it is her decision to decide how she takes it forward. So the final outcome must be good for both the mother and the baby. What is good is a sort of subjective thing. Now, this is another pregnancy, IVF DCDA twin pregnancy, with one baby having increased nuchal translucency and hypoplastic nasal bone. Now, she had that at NT scan, and then she opted for NIPT because of the same reason. This is another case. The same reason, like we said earlier. Now, look at this. She had an NIPT because what were we worried about? We were worried about Down syndrome. Now, the NIPT gave us high risk for trisomy 13. We know that NIPTs are notoriously false positive for anything other than Down syndrome. For trisomy 21, they have a very high sensitivity and specificity. But for other trisomies, for sex chromosome abnormalities, they may be very, very, there may be false positive results. So here again, she was hesitant to do an amniocentesis for Down syndrome. Now we have an NIPT positive for trisomy 13. But trisomy 13 is a condition which generally presents with multiple malformations, severe IOGR, lots of things on the scan. Very unlikely that you see a baby which is completely normal and that also has trisomy 13. After that counseling, she kind of decided, let's not do anything further. She continued the pregnancy and both the babies were normal. Now you would say, what happened to the NIPT? Why did that come? Let us not forget that NIPT is a screening test, and the source of DNA in NIPT is also the placenta. So there may be conditions which are placental mosaicisms, and that is why NIPTs can come positive and babies may be normal. Had we done an amniocentesis, we would have found everything was normal. She deferred the decision for amniocentesis, which is why I'm telling you this in this forum, that they decided not to do an amniocentesis. So when people after a positive NIPT decide not to do an amniocentesis, the decision should not be to terminate the pregnancy. The decision should be to continue and see whatever it is thereafter, because there is a high chance that the baby may still be normal. Now, this is Mrs. R. She again conceived twins after IVF, and her first trimester risk gave high risk for trisomy 21. Can you see that? Trisomy 21 more than 1 in 50. So they had amniocentesis. This couple was more sort of brave, and they said, we'll have an amniocentesis. And here we were worried about trisomy 21, but one of the fetuses had a deletion on chromosome 4. And this was an unusual thing to find. They didn't have any finding on the scan. The findings were only because of this thing, and there was a history of increased NT, of course. But at that time, when we saw at 16 weeks, both the babies were normal. Yet when we did the amniocentesis, the child which had increased NT had chromosome 4 deletion, and they opted for a selective fetal reduction of that twin, continued as a singleton, and delivered one healthy baby. This is Mrs. M, who conceived with IVF and had a procedure called sequential embryo transfer. Now, sometimes we come across these babies where they say that they transferred one baby on one day and another one on another day. And in these cases, we are really confused as to what to take as the correct gestational age, because dating of pregnancy, traditionally we date the pregnancy based on the bigger CRL because we assume both have been conceived at the same time, and therefore the one which is bigger is more physiological. There could be early IUGR and we don't take the small one. But here, both are physiological because the second one was actually transferred later. Until now, we are not sure how to date these pregnancies. So the pregnancies with sequential embryo transfer, we use NIPT because it is independent of the gestational age, and we use NIPT for screening. This one was one such case. We did that, and luckily the results were low risk, and her pregnancy went on uneventful and things went fine. This is another unique case that happens in IVF. We do pre-implantation genetic testing. This is done in women who are of a certain age because they feel that this reduces the number of aneuploidies in the embryos. Now look at the history. She is gravida 3A2, and she had 2 early miscarriages in the past, and this time she decided to have IVF with her own eggs and underwent pre-implantation genetic testing. But once they tested the embryos, most of the embryos which were not good were discarded, and the embryo which was somewhat better on visual inspection had low level mosaicism. Now, the IVF doctor went through a lot of discussion, and she discussed with me also. And she said, this is the only embryo which I feel I can transfer, but it has low level mosaicism. So I said, fine, if you want to transfer, you transfer, and we'll see her after birth. If it is abnormal, it should have another miscarriage like she had before. And if it stays, then we'll see what we do that. So at 6 weeks, she came back. We explained the implications of the PGT report. Luckily, the implantation was successful. And we told them that ultrasound alone cannot, rule out things. So we will do a amniocentesis at 16 weeks. Now, this is a couple which knows that the embryo that has been transferred has low level mosaicism. And all of you who are IVF experts will understand that even mosaic embryos can be transferred. And if they are good, evolutionarily, the mosaic part goes into the placenta, and the normal chromosomes they can become part of the baby. So what should we do here? A CVS is not a recommended thing. Here, it is better to do an amniocentesis, because then we will be checking the fetus directly, not the placenta. So this was an elective plan made right from 6 weeks, that whatever be the progress of the pregnancy, we will do an amniocentesis at 16 weeks and send for fission microarray. Couple karyotype was checked, and that was normal. So this was low level mosaicism. We were worried about a lot of things. So the FISH report came back normal. So there was no major aneuploidy in the pregnancy. But the microarray showed a loss on chromosome number 19. Now, again, just think through with me. This is a couple which knows there is low level mosaicism. We are all anxious, and the microarray report is abnormal. It does show something which is a loss on chromosome 19. Again, the knee jerk reaction will be the report is abnormal. But wait, don't get anxious. What does it say? It says variation of uncertain significance. And I must say that this couple was one of the most sensible couples I've met in many years. And once I told them that, look, this is variation of uncertain significance, let's just work it through. And what we did is we checked with the clinical geneticist. We always send to the clinical geneticist whenever there are uncertain reports, because uncertain significance is uncertain. We cannot take a decision on uncertain significance. So she went through the database. She says it is uncertain. Let's check the parents. Let's check the parents and see if any one of them is carrying a similar loss. And the karyotype was normal, but this is a microarray level report. So a parental microarray was done, and it was seen that the mother herself carries a similar loss in chromosome number 19. And therefore, it was discussed that this is not a problem. Even if the embryo was mosaic, even if the microarray says an abnormality in chromosome 19, this is a physiological abnormality because mother herself is carrying a similar microarray. Let us continue the pregnancy. So they have been told that they can continue the pregnancy, and baby will be checked after birth. We don't expect any problem in this pregnancy, and we are continuing this. This was another case where it's a DCDA twin pregnancy. Now, one baby had multiple abnormalities. There was a large VSD, suspected complex heart defect, single umbilical artery, polydactyly. Things looked really bad in that fetus. The other one only had urinary tract dilatation. So it was like urinary tract dilatation can be managed after birth. So this patient said, look, I have already spent all my money in IVF. I have very little money, but I want to save at least one baby if I can. So I would like to, just continue this pregnancy and take care of the UTD baby later on. Then when we discussed that there is possibility of genetic conditions and all, she said, okay, fine, just check the baby with the UTD. Do not check the other one, because we know that the baby might not survive and we will not do anything for that baby. So we just check this baby. If this baby is normal, maybe we will consider reduction. So that was the plan. Again, this kind of plans cannot be made on textbook knowledge. It has to be done on a one-to-one practical discussion. So they were very clear. They said, we are not going to go for cardiac surgery postnatally. If at all, we'll do palliative care for that baby. If this other baby is completely normal, we may opt for reduction, but let us check this baby. So we checked the abnormal baby. We checked the baby with the urinary tract dilatation, and unfortunately that also had a heterozygous dominant likely pathogenic mutation, which can be a Noonan-like syndrome. So we actually told them to go to the clinical geneticist and have more clarity, but I think by the time they just lost it, they went to their obstetrician and terminated the entire pregnancy. So appropriate communication is very important, giving complete information, a sensitive and non-judgmental approach. Allow time for the couple to decide, and you will realize there will be unique decisions in each case, because the whole population which goes for artificial reproduction has unique problems. Mrs. M conceived with IVF with her own eggs. She's had two previous pregnancy losses which were not evaluated. At 12 weeks, they had an NT scan, and on probing further regarding the cause of the previous losses, we found a surprise twist. Now, they had a genetic syndrome called Krabbe's disease in their previous pregnancies, and this was not told to the IVF doctor. Also, the IVF doctor did not ask what was the reason there were problems in the past. So she'd lost two babies because of Krabbe's disease, and she had not revealed this to the IVF doctor. So here I would like to, just bring this to the notice of the doctors who are doing ART, that ask the history in detail. Do not just go off for a, whatever history they give you, because it is not a miscarriage. There was terminations because of Krabbe's disease. And this is the whole story, that, if you have Krabbe's disease, there's a 25% chance of recurrence in the next pregnancy. Now, if you don't tell the doctor that why are you doing an IVF, the whole concept is lost. In these cases, if you do an IVF, you will probably use a donor gamete, because that only will undo the reason for the problems in the past. Just doing an IVF does not absolve them of the risk of Krabbe's disease again. So the dilemma now is, again, we have to do a prenatal diagnosis. And now, without any proven molecular diagnosis, it is very difficult to do these. And then there's a risk of miscarriage. And then the whole question about why was the IVF done without this kind of clarity. So whenever we look at patients, history taking is very important, especially in ART. The drive for most of the centers to do number of cycles in every month is making this a little bit of a gray zone, where people are not taking the history properly and not realizing that preconception workup is very important before a woman is taken for artificial reproduction. I really wish sometimes doctors paused and thought a bit, because I was once very disappointed to see this 26-year-old primigravida who had IVF came for a fetal echo for a DCDA twins at 26 weeks because of poor visualization. The scan was okay. We managed to see everything and it was good. But when I took her history, she had history of epilepsy. She was suffering throughout her adolescent age group with epilepsy, was on irregular cycles, but irregular treatment, but just stopped treatment after marriage. She just did not consult any neurologist and has not told anyone because nobody asked. This is a woman who is a known case of epilepsy. She's just not revealed it because nobody asked. And her BMI was 42, some 128 kgs weight. DCDA twins, 26 weeks, history of epilepsy, not being treated. I was feeling very scared. And I just wished that, the doctors had spent a little more time, because this case selection would have been completely different. You would have waited, you would have asked her to lose weight prior to the conception. You would have treated her epilepsy, at least got a neurological consultation, because we are plain lucky that things went well. but she could have had congenital anomalies, she could have other issues. And even now, 128 kgs, having twins at 26 weeks, if she throws a fit at some point, what a bad clinical condition that is. So somewhere all of us need to pause and understand that, IVF or ART has given us the power to make everybody pregnant, but where to use it and where not to use it has to be a very, very conscious decision. This is another unique situation where you have unicornuate uterus and then a woman conceives DCDA twins. I wish the doctor told me that I had done a single embryo transfer, still it happened to be DCDA, but she had done more than that. So here they were referred for reduction because unicornuate uterus will not have that much of capacity. The evidence is very patchy in this. I will not be surprised if many of you will object to what I'm saying here. But after a lot of discussion, lot of understanding, the couple said, no, we won't take a chance with twins because just in case there is a rupture or there is a problem, we can't handle it. So a reduction was done. The discussion that we had or the counseling that we had is if at all there is a miscarriage, it will happen now and that can be dealt with in this uterus. But if something happens at 25, 26 weeks, they will not be able to have a reasonable path out. So they opted for a selective fetal reduction. Fortunately, it went well. Why I'm saying fortunately is all these procedures are fraught with dangers and sometimes there may be miscarriages after such kind of reductions, and then it is a situation where all of us feel bad. Luckily this went well and she delivered a term baby, it's like a singleton thing, but again the evidence is lacking as to what is the exact right thing to do. Sometimes patients with ART have problems. For example, this one had a large ventricular aneurysm. I don't know how comfortable you are reading the scan reports, but here there is one of the twins had a ventricle which had a very abnormal shape. If you can see, it is dilated and has a ventricular aneurysm. And that led to a lot of discussion in the antenatal period, but they were very, very committed to the pregnancy. They continued, and you can see that a large ventricular aneurysm in the heart. And she went on and delivered at full term and had a good outcome. There are some other kinds of complicated multiple pregnancies like dichorionic triamniotic triplets. If you see here, this is a retroverted uterus with dichorionic triamniotic triplets. Now, there is a lot of dilemma in these pregnancies. They have conceived with IVF, they're very happy, but they don't want to continue as triplets. And even if you want to reduce, most triplets which are trichorionic are reduced to dichorionic twins. But in this case, what do you reduce? If you reduce the singleton, you're reducing the healthy baby because these monochorionic twins can have all kinds of complications. If you reduce the monochorionics, you have to use special methods because regular potassium chloride based reduction cannot be done for them. So that is a long counseling that happens with all couples who come with this kind of pregnancies. And they want to continue if it is safe, but when there are problems, they would like to undergo reduction. So whenever you do reduction in dichorionics, you can easily cause asystole in one of the babies by potassium chloride. But when in monochorionics, you can't do that because there is a backflow problem. So you want to disconnect the circulation. So in these cases, you use procedures like radiofrequency ablation or microwave ablation, and that is what is done in these cases. So here, one of the cords of the monochorionic pair was coagulated at 16 weeks, and she took home DCDA pregnancies. So we have also had these situations with monochorionic triplets, and at least two of them have taken home monochorionic twins without complications because the pregnancy has gone successfully. But at the same time, all these reductions don't go well. Many of them have problems also. So these are restricted for extremely, extremely unique situations. This was a patient similarly DCTA who decided that she wanted to reduce, and we called her at 16 weeks for that reduction. Now, when she came for the reduction, what happened was we saw that the mother had problems initially. She had severe UTI, she had renal calculus and was sent for urology workup. So the reduction got deferred. Later on, when we saw her again for reduction at 18 weeks, the single baby, which was the healthy one, had this kind of kidneys, hydrouretronephrosis. And now it was very difficult because when you touch the monochorionic pair, you can cause a miscarriage for both. So if you cause a miscarriage for both. You're leaving behind another baby which has this kind of hydrouretronephrosis. So is that a correct decision? Is that not a correct decision? And then, after that long discussion with the couple, they decided, okay, well, let's defer the whole condition and let's just wait, because at 16 weeks we were not able to do it because mother had UTI. At 18 weeks, one of the babies has hydrouretronephrosis. So we just waited. And by the time she was 22 weeks, it was surprising to see that all the kidneys looked okay. Even the one which had hydrouretronephrosis, you can see down there, didn't look so bad. But by the time she was 22 weeks and we all were comfortable, so we just continued the pregnancy as it is. And ultimately, she delivered three male babies at around 32 weeks, and all of them did well. So, this was just nature's way of taking care of this pregnancy, because each time a decision was made, there was another reason for which it was deferred, and for some reason it just continued as triplets, and she did well even if it wasn't. And we have so many of these cases now that I have lost count of how many triplets continue because of unusual reasons. But if the outcome is good, we're all happy. If the outcome is bad, at least they know that they have taken that decision to continue, and whatever is the outcome is their thing. So what we do is apply the most reasonable corrective measure. There is no clear-cut answer as to what should be done. Now, coming to another scenario, we just discussed that, if you have a genetic condition and you know it, in any pregnancy, you can always do prenatal diagnosis. This was a couple who had a known mutation. Every time they were losing pregnancies because of a known condition, which was a gene in that was related to hypophosphatemic rickets and some GAC1 type of general arterial calcification of infancy. So this pregnancy, they next pregnancy they will have a CVS. That is the plan, isn't it? When she was waiting to get pregnant, she met an ART consultant who gave her ovulation induction. And she came to us at 8 weeks because she knew that we'll do the CVS. But this time she had pentachorionic pentaamniotic pentuplets. Now, this is such a frustrating situation because each fetus has a 25% risk of having the genetic condition. We know that we can offer a CVS, but I don't know if any the fetal medicine specialist will be able to do a CVS for 5 fetuses at the same time, because it is just not physically possible for us to access each and every placenta separately and label them separately while doing the procedure. So it's again another very, very unique challenge for us to deal with this. And after long counseling, what we decided was we empirically reduced 3 fetuses at 12 weeks, waited for the risk of miscarriage to pass on, and then at 16 weeks did an amniocentesis. They were told that it may be possible that both the babies might be affected, and you might then regret that the 3 babies that you reduced were normal. But luckily, when we did the amniocentesis, one baby was normal, although one baby had the same condition. And then we did a subsequent reduction, and she went on with one baby, one healthy baby she took home. So this is not an ideal situation, but you do what you can do, because sometimes common sense medicine also works. This is a lady with IVF, 34-year-old, who came to us at 21 weeks, 5 days. She was referred because she had polyhydramnios, pericardial effusion, and ductus venosus systemic shunt, and a suspected chorangioma. So when we did the scan, this is what we saw. So the heart, we are showing pericardial effusion there. The blood vessels, which you can see in the fetal abdomen, show a kind of shunt that is called the DV shunt. And in the placenta, you can see a large tumor with a feeding vessel, and that is nothing but a placental chorangioma. So if the feeding vessel has the spectral flow of an artery there, you can see that. And if you continue to carry on this pregnancy along with this chorangioma, there is a very high risk of fetal hydrops, because polyhydramnios and pericardial effusion has already set in. And then there can be all other problems with polyhydramnios. So in this particular pregnancy, what we did was we did a coagulation of that particular vessel there. We did a coagulation of the feeding vessel of the chorangioma, and this was done at 21 weeks gestation. And by 24 weeks, things had got better, or the effusion was still there, but it was getting better. The blood flow in the chorangioma stopped. There was a ductus venosus systemic shunt, and this pregnancy was followed up repeatedly to look for any changes in the circulation. The ductus shunt was also followed up. At about 30 weeks, she had a abruption, and then she went and got delivered. And luckily, the baby is doing well post delivery. The ductus venosus shunt closed and did not cause much of a problem. And the placental histopathology showed a chorangioma with no signs of any malignancy. So the baby went home and did well. This was again one situation where multiple problems were there, and the patients were very resilient. They were willing to do anything that you can do to save that baby, because there was a high risk of hydrops in that pregnancy. So at 21 weeks, we went in and did a massive procedure in the placenta, and she took the baby home at 30 weeks. And post delivery, the cardiology review was perfect. The ductus venosus shunt closed gradually, and she did not have a lot of problems. So they are finally thankful, and they did well. This is another pregnancy with a 34-year-old lady, IVF with her own eggs. And she had a previous ectopic pregnancy, and she was referred to us because in this pregnancy, when she was already diabetic on insulin, NIPT was low risk, but in the second trimester, she developed hydrouretronephrosis, a unilateral club foot, and hypoplastic nasal bone. Now, again, NIPT does not suffice for these conditions. So just doing NIPT is not enough if there are scan-based abnormalities. So she came to us in April this year at 16 weeks, and we saw that the kidneys were not looking very good. There was bilateral hydrouretronephrosis, there was unilateral club foot, and hypoplastic nasal bone. So after discussing with them, we said if NIPT is normal, that means major problems we don't have, but there could be minor, some genetic issues, or maybe some microarray related issues. So they agreed for testing, and we went ahead and tested the baby. The reports came out normal. There were no problems, but the hydronephrosis kept on increasing. As you can see here, the kidneys kept on looking bad. The cortex was echogenic, and the bladder is large and thick walled. So at one point, I told them that, the outcome might not be great. It's 21 weeks. The Liker also was relatively less. And the role of shunting in these cases is very questionable, because the Pluto trial has said that it doesn't have a good outcome. However, the couple said that whatever you can do, please do. Even if it means we have to do transplant for the baby postnatally, we'll do it, but keep it alive as a fetus, and we want to take home a live baby. We will deal with everything else later. So I did a vesicosynthesis in this patient, and the urinary electrolytes were examined. Most of them were okay, apart from beta-2 microglobulin, which was slightly on the low, adverse side. But despite that, next time when we saw, the Liker was good, and the thickness, that tense bladder was not there. There was some urinary emptying that was happening. And we kept on looking at this, because the couple were very keen on continuing the pregnancy. And we took the pregnancy up to, say, 36 weeks, and delivered the baby at 36 weeks because she was also GDM on insulin. She had multiple other issues going on. The weight of the baby was 2.59 kgs. And just after the birth of the baby, we saw the various features. The urinary outflow obstruction was confirmed, and the posterior urethral valves were considered as the reason for that. The creatinine started rising postnatally, because the placental clearance stops postnatally, and then the fulguration of the valve was done after 2-3 days. And finally, the baby went home on like the 10th day. There was a casting done for the club foot, and this baby is carrying on. Lots of things are going on, but the parents are happy. You can see the cast in the foot there. You can see that other things are being taken care of. So there's a lot of care that is being required by this baby, but the parents are happy. This is what they wanted. And touch wood, the kidneys are not that bad now. One kidney is bad, the other kidney is taking on the function, and the baby is not requiring any aggressive renal therapy right now. I hope it doesn't. The club foot had to be operated. So there were multiple things in this baby, but the parents, their resilience was enormous and they wanted to continue. Similarly, we had another pregnancy where there was short long bones and retrognathia. Now, she had come screen positive for Down syndrome. When we saw, you look, the femur also looks curved. This is a 12-week scan where you can see the thigh bones are also curved. We told them the chin looks small, the thigh bone looks curved. They said, we'll wait and watch. 16 weeks when they came, the chin was very, very small and the thigh bones were very, very curved. Still, they said, we'll wait and watch. And the bones were all small. We did testing for the genes and chromosomes. Everything came back normal. But the baby kept on having these small bones and continued. Parents wanted to continue. That's what when Dr. Chamla was saying there can be medical legal issues. Now, this was a pregnancy which every time they were told about the uncertainties, they met the pediatric orthopedician, the serial growth scans were done. She went on to 36 weeks, 3 days. She delivered a baby which was 2.2. Now, this baby looked okay at birth. For 3 days, it was okay. But after that, it just did not do well and it succumbed at 3. We don't know the exact reason. The chin looks small thing, but they delivered in another center. We don't have a complete follow-up there. And that is where I say that there should be a complete follow-up because we need to exactly understand what was wrong with the baby, but this baby didn't do well. However, the resilience of the couples is humbling. They call us and they tell us the outcomes. They accept the fact that, okay, things didn't go well. You had told us that there might be some problems. And many times we don't know the exact answer about why some babies do well and some babies don't, because in terms of genetics and chromosomes, our results were normal. So honestly, I do not know what was the problem with this baby, but structurally there were multiple issues. So we don't know whether the bones only were very brittle, whether the baby could not maintain saturations because the thorax was small. I still don't know, but the outcome was bad. However, the couple understand that this was told to them, this was understood, and they went on. This is another case where she had a previous antepartum stillbirth at 32 weeks, did not know why that happened. And in this pregnancy, without any screening, they came at NT scan because somebody told them there are echogenic kidneys. Now, NT scan, echogenic kidneys is very difficult to assess because sometimes that may be very physiological. It's difficult actually to take a call. And the couple were keen on continuing the pregnancy. The kidneys did look large and echogenic, but we said, wait. 16 weeks, we saw again. So all these places, we are unsure. We don't know whether it's normal or abnormal. But when you talk to the couple, they understand that you are trying your best and you will wait and you will give them an outcome that is rational for them. So she came back by 16 weeks. It was still echogenic, but amniotic fluid was normal. Everything else was fine. We gave them the option of doing amniocentesis and testing for cystic kidney conditions. They didn't want to do it because they said, whatever it is, we are going to continue the pregnancy. So they continued the pregnancy. The kidneys were echogenic. The liquor was good. And this went on. And we took the pregnancy to as much as possible. In the third trimester, she had growth restriction. By 29 weeks, the growth was on 8th centile. The umbilical Doppler was showing high resistance with positive end diastolic flows. MCA showed redistribution. DV Doppler was normal. Kidneys were okay. And she delivered at 30 weeks, 3 days with abnormal Dopplers because we had reverse diastolic flow. We had to deliver the baby. A male baby of 1.1 kg, 1.13 kg was delivered at 30 weeks of gestation and then kept in NICU. The baby stayed in NICU for almost 3 months and had an enormous bill, I can tell you. But the couple were so resilient. They listened to everything that was told in the NICU. They continued and finally they came back and thanked us, for which we felt very humble. But sometimes the outcomes are good. Sometimes the outcomes are not so good. The thing about artificial reproduction is couples have gone through a lot till they achieve that pregnancy. And when the pregnancy is achieved, the first joy is when the pregnancy test is positive. And then if everything goes well, they are super happy. But fetal care in these conditions is so difficult because there will be challenges where screening tests will be abnormal, or there will be multiple pregnancies, or there will be a fetal anomaly. And in every situation, the moment there's a question about the fetal health, the couple become very sad, very, very disappointed because, their whole aim was to take home a healthy baby. Who doesn't want a healthy baby? But not everybody is ready to just discontinue because there is a problem. And not everybody needs discontinuation. Sometimes it makes sense to just talk to them and tell them that, look, I may not be very sure, but this is what can happen. Are you ready to accept it? And you will be surprised with the answers. That kidneys were so bad. I told them, look, this is bad. You will need lots of intervention. Most people, most healthy people, most people who've conceived without assistance choose to terminate because they feel they'll just get another pregnancy. But people who conceive with artificial reproduction have a very, unique attachment to their fetuses, and they really, I don't say that others don't, but mostly people with ART will have that, and we must consider that while we counsel. We should not let our judgment get over them, because we have to use common sense, judgment, and a lot of individual circumstances and the patient's autonomy. The whole concept of medical ethics is beneficence, non maleficence, justice, and not doing any harm. So we do not want to cause anything wrong by our thing, but try to solve the dilemma with a correct choice so that all's well that ends well. We always have to balance the odds. And in perinatal care problems, in all these unique problems, we always tell them that, we may not be able to cure everything, but we can certainly care for everything. And here I would like to acknowledge that one cannot do this kind of fetal care on your own. I cannot work alone. I do not work alone. All the work that you have seen, which we have done, has been a result of a very strong and committed team that stands behind me, because anything, even counseling for that matter, is a multi-person job. You don't know language sometimes. You may know the language, but you can't sit in their mood for a long time. You cannot afford to spend that much time all the while. So if you have a good committed team, you can break your counseling into pieces. Multiple people will tell the patient the same thing, and they will feel empowered with the information at the end of it. So it's not just medicines, it's not just procedures, it's not just a prescription that solves your problem. In care of the fetus, in any pregnancy for that matter, but especially for artificial reproduction babies, it is important that just be there for them. And to be there for so many patients, you also have to be so many people. So I'm very proud of my team, and I thank all of them for making it possible for us to do this kind of work, which we can share with you. Thank you, Janmila ma'am, for the opportunity to share these cases with the esteemed audience here. And if there are any questions, I'll be very happy to answer.
Thank you, Chinmay. It was like listening to a thriller movie and or novel. Like I was wondering, like, what will happen next? What will happen next? And such a beautiful collection of cases, I would say, because
Thank
everything
you.
was so different from the other, and the learning points are very, 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 very significant, I would say, because when we are practicing assisted reproductive technologies, we always feel that the end point is a pregnancy, but I've undergone so much of problems, because when you don't have a idea of like how to manage a particular pregnancy, you will not know when to refer also. So that will create lots of problems as far as ART is concerned. There's one question from Dr. Jayalakshmi in Coimbatore, and she has asked, which is a prenatal screening test for triplets?
So, madam, for triplets, it is always a scan-based screening, because the biochemistry works well only till twins, and that too when we adjust the moms for chorionicity. So in pregnancies that are higher order multiple pregnancies, that means more than two babies in utero, it is better to stick to scan-based screening. So you can do an NT scan individually for each fetus and give them the risks. If it is monochorionic, for example, if it's a dichorionic triplets, then the monochorionic pair will have the same risk, just the same concept as we do for others. And the one with the separate placenta will have individual risks. But we do the thing only. There are some papers where they say that we can do NIPT for triplets. Currently, our labs in India are not yet empowered for that. It'll be a lot of confusion. So it's best to do scan-based screening. Any doubt, directly test the fetus.
Dr. Nagaraj Shimoga said, excellent presentation.
Thank you, sir.
Same sentiments by Dr. Alluri Samira. Dr.
Thank you,
Radha
thank
Lakshmi also said excellent presentation. Dr. Jayalakshmi has said excellent as usual. And Dr. Anjalakshi has said, congratulations, Chinmay, excellent collection of cases. And Dr. Usha Dave said, very good sharing of experiences.
Thank you, thank you so much.
Yeah. I had one question, like I had an IVF pregnancy, and the patient around when we did an NT, there was an intermediate risk as one of your patients had. It was a singleton actually, own eggs, own sperms it was. And then the fetal medicine specialist who comes to my place, who's your student by the way, so she offered an amnio for them. But because she had conceived after 20 years of infertility, they said they don't want even that slightest risk of a miscarriage. So they didn't do an amnio. And the anomaly during in the fifth month scan, everything looked okay, except for that echogenic focus, which everybody reports nowadays. Then at around 30 weeks, when we did a scan, we picked up a congenital diaphragmatic hernia. So I gave them the choice of going to a pediatric unit for delivery instead of having it in my place. So they chose a hospital in a big center in Chennai. So they went there. So surgery done, everything went on fine. But after 6 months, the baby succumbed. So they have filed a case against us. And against me, what it was like, why didn't you say that anomalies can happen in IVF pregnancies? And we didn't get a signature from them when we did a counseling around when we found that intermediate risk. Should we have we should have taken a consent for that you have counseled them?
No, no. There's nothing there because uh, the intermediate risk was for trisomy 21 and
Yeah.
the fetus did not have trisomy 21.
No,
If it had
no,
trisomy 21, you would have
no.
known. So
Yeah.
that is a moot point now. I mean, what would
Yeah.
you have done? You would have done an amniocentesis and ruled out trisomy 21. So there was no trisomy 21.
21.
Then the diaphragmatic hernia, which is picked up in the third trimester, usually, see, whenever there is a diaphragmatic hernia, the defect in the diaphragm is there right from 10 weeks.
Okay.
But you see it on the scan because you see the effect of that defect, which is in the form of the intestines and the stomach coming up into the hemithorax.
Hemithorax, yeah.
Sometimes it doesn't come all the time. It's a sliding variety of diaphragmatic hernia. So you may not even pick up in the third trimester. And this literature is very strong about this, is that when it is picked up in the third trimester, the outcomes are good.
Okay.
And therefore, this patient was counseled correctly and she was sent for surgery. She's had the surgery. The baby was alive for 6 months.
Yeah.
So the diaphragmatic hernia part was sorted out because the diaphragmatic hernia leads to problems because of lung hypoplasia.
Yeah.
And lung hypoplasia will lead to demise of the baby in the first 2 or 3 days. Most of our cases of diaphragmatic hernia which continue and don't do well, the problems happen in the first 48 hours. Either before or after surgery, the baby does not do well because the lungs don't recuperate. If the surgery was done and the lungs recuperated, then everything was fine. So after 6 months, the baby could have gone for any complication. They might be having.
I'll tell you like what happened. The baby had some infection and they did not come back to the pediatric unit, and they were looking. The baby was looked after in its own local place.
Absolutely.
And they were like moving from one hospital to the other, so the treatment was not done according to, and the hospital where they were operated on, they kept on calling them back, saying like, come back, we will need to evaluate why the baby had respiratory infections again and again. So they said we need to evaluate, but they never brought the baby back. And then after it succumbed, then they filed this thing. So, and we have always in an IVF pregnancy, we get a consent even before the procedure that there's no assurance that you'll get a fully normal baby after delivery. So IVF pregnancy per se has its own problems because you do so much of manipulations before the mother conceives. So we know that there's an epigenetic and genetic changes which can happen per se because of the procedure. So we get a consent, and the consent has been signed by the couple. So still they go on. So that's what I'm saying. The point is IVF pregnancies can never be simple. Even if it's a male factor, we have seen so many complications happening when the mother is delivering also. So that's why we wanted you to talk on this subject, because people tend to think help the mother to conceive and push her off to one place. It's never going to go back. She's going to come back if there's going to be a problem. So counseling is very, very important as far as IVF pregnant. That was my experience, because I was totally like in a daze, because I thought I'd referred her in time and to a proper place where it is one of the best centers in India itself. And then you come back and tell me you didn't tell me that there's going to be an army. Then I was wondering like whether I should have got a consent every time when the couple visited me. And that is not possible. How can you get a consent for every consultation you give? So the point is like, It's very difficult
You have
sometimes.
to counsel, ma'am, and you cannot document everything all the time because there is a lot of hand holding that happens, which we cannot document. There's no way of expressing it also.
Yeah.
Now, this is just unlucky and I would say unfortunate because the patients react differently in different circumstances. We should be sure that we have told them everything. We have, like what you have done, that is what you could have done.
Yeah.
So it is very much defensible. It is just unfortunate that it will still land up in some kind of,
I'm used to medical legal cases now. I've become an activist actually. So I don't bother. I just take it and I continue my work. So that we accept. But what I'm saying for the youngster who's joining into reproductive medicine, don't think it's easy, just conception and you send off the patient back is not going to help. You need to follow up the mother. And as Chinmay said, telling the age of the donor is extremely important when you're managing the fetus. And they don't even check what the age of the donor is when they've taken the donor eggs on. That is not defensible at all. So many points you gave are very, very critical, I would say, as far as a IVF specialist is concerned. Because it's not just because earlier days they just used to help the mother to conceive and the mother will be referred off to another center for delivery. And you are not going to escape if something goes wrong there also. That's what I want to say. There's Dr. Narayan Jana who said it's an excellent program.
Thank you, sir.
Dr. Divya has asked, like, what is your opinion on doing extended NIPT for genetic abnormalities other than 21, 13, and 18?
So some of the labs are offering the extended NIPT, but they are also giving a small disclaimer there that the sensitivity is not as good as for trisomy 21. So we have to discuss this. I mean, I can't say that we've never found abnormalities beyond Down syndrome in NIPT. We have detected a few problems in chromosome 17 or A15 without suspecting it because it was an incidental finding. So that happens. So again, a lot of counseling to the couple. Tell them that, if we find something, what happens if we do the extended for the fetal medicine people, it's good because it is like we do the NIPT and we find another reason to do an amniocentesis. Ultimately, the final answer for the fetus is amniocentesis. The purpose of the NIPT is to avoid an amniocentesis. But if the NIPT gives false positive results about anything, you end up doing amniocentesis. So you've not done the amniocentesis for trisomy 21, but for something else, which may again come as normal or abnormal because there are many reasons for false positive NIPTs. One is placental mosaicism. Second, mother may be carrying some kind of mosaic factors herself. People who are very obese have some unusual, DNA there. People who've received blood transfusions, and that is another thing we should be careful that we are not taking it from a woman who's received recent blood transfusion, organ transplants, things like that. Rarer variety, or if the mother has some kind of malignancy going on in her body. So many things can lead to unusual DNA in the mother, which will be perceived as a false positive. So it comes with its own advantages and disadvantages. So counsel the patient and do whatever they want. Usha ma'am has asked about mitochondrial disorders. So ma'am, I mean, we'd refer to the geneticist and take that opinion from them. Because any kind of mitochondrial disorder, if you're taking a donor ovum, you will be able to get over that. But that will require, instead of a very generic answer, I'd say if you have any genetic condition and you're planning an IVF because of that genetic condition, then it's better to talk to the clinical geneticist in advance and decide what you want to do, whether you want to do the PGT for that particular single gene disorder, or you want to do, gamete replacement. That will be a decision with the clinical geneticist and the couple together.
And I think Dr. Divya wanted to ask on micro deletions as far
same
as
thing, that extended NIPT is for micro deletions. So that's the same thing.
Okay. Dr. Uma has asked on an opinion on third trimester anomaly scan.
Very important, madam. So it is not like we will call it a third trimester anomaly scan, but whenever we see the fetus, we try to check the anatomy as much as possible. It is okay to write a disclaimer that we can't see everything, but in a third trimester scan, even if you have seen the fetus in the second trimester, just relook the four-chamber view of the heart, because things like coactation of aorta can be evolving. So you may see a chamber discrepancy in the third trimester. You may see some heart block or something in the third trimester. The stomach bubble might not look so big as it was looking earlier. There might be mild polyhydramnios. That could be your first indication that this may be connected tracheoesophageal fistula. You may see dilated bowel loops. You may see hydronephrosis. So try and see as much of the ISWAG has given a clear-cut guideline about what all can be seen in the third trimester, which are evolving anomalies. And therefore, just like that, the diaphragmatic hernia was picked up in the third trimester. So if in the second trimester, you've got good pictures of the thorax and it was not there, then in the third trimester, it could have evolved because it might have been a sliding variety which did not present earlier. So third trimester anomaly scan is important. That counseling before the scan and after the scan is also important. And we tell the patients that it is not because we are lazy or stupid, but it is just the way anatomy is that we cannot pick up everything. So telling them is important. The role of NIPT regarding anomalies. NIPT is not recommended when there is structural abnormality in the baby, because structural abnormality should necessitate checking all the chromosomes, and that can only happen by direct testing. So ideally, NIPT is not recommended. Non-ideal situations will be individual one-to-one discussion. Counseling can be on recorder by video and voice recording, though not admissible in courts.
That's for me. That's for me.
What,
That's for
what
me.
is your
No, they are not.
opinion?
It's not admissible in courts. So whatever you get in writing is good enough, and mine is quite good enough because I'd had a proper counseling session with them, and they'd signed that they accept that they may not be a perfect baby when it's born. So I'm quite safe. But getting a voice recording is not going to be an added advantage anywhere. Your written consent is more than enough. And then Dr. Anita Rajoria has asked, comprehensive screening and the timing of the test you would like to do for IVF conceptions, keeping in fact they are at high risk for preeclampsia too.
Sure, ma'am. So the same test that we do, we wait for the first trimester scan between 11 to 14 weeks. If the scan is completely normal, then we go for the standard double marker test and do the PAPE and beta HCG. If you consider them high risk, because you do a uterine artery Doppler as part of the first trimester scan. So if that is high risk, then she goes on the, prevention of preeclampsia by low dose aspirin at that point. And then you do second trimester scan. If the first trimester high risks are normal, she doesn't need anything else. If they are high risk, if the second trimester scan is normal, then we offer NIPT. If the second trimester scan shows some findings, then you can offer amniocentesis and then carry on. Usually we refer 4 to 5 weeks growth scans, because it just keeps everything in perspective. What we tell the patient is the only thing that changes in pregnancy is the fetus. So instead of the mother going repeatedly and just showing herself to the obstetrician and thinking that things are good, it is good to check the fetus also, so that you know that what is growing inside is growing fine. So maternal and fetal both have to go together in these pregnancies.
Yeah. Dr. Kalachelvi has asked, can routine growth scan be done in third trimester and what time? I think you have answered that.
Yes, ma'am.
Big list is there. So you have to do a third trimester scan, particularly in an ART pregnancy. Don't miss out, because late FGRs also can happen and you may suddenly have a stillbirth sometimes. Be very careful in IVF pregnancies, because for both placental as well as genetic problems there. Dr. Anita said thanks for that. So only one more question before we wrap up. I had a query from one of my friends from Thuthukudi, Dr. Rajasmin Tilak. She said one of her patients had a stillbirth, but they had identified placentogmegaly in her scan. So the next time when she had a patient with placentogmegaly, she asked me like what to do. Like what is exactly the pathology there when there's a placentogmegaly?
So, ma'am, placentogmegaly is a placenta which has more than, earlier we used to say 4 centimeters. Now some of the papers are saying 6 centimeters in terms of the width of the placenta. Okay. So these are also known as large jelly-like placenta. And if you do histopathology, usually you find a condition called placental mesenchymal dysplasia.
Okay.
Just like cirrhosis is not an ultrasound diagnosis, mesenchymal dysplasia cannot be an ultrasound diagnosis, but we suspect that a lot. Okay. And we see that in patients which will then present with early onset growth restriction and then go on to have bad Dopplers. So it's just a manifestation of a badly formed placenta. Okay. The placenta has a very nice network of, blood vessels, and it has to be packed in cotyledons. So that is a very poorly formed placenta, which is large but not functioning very well. So you can't really do anything because you cannot change the placenta. But once you see something like that, you corroborate with the uterine artery Dopplers. You know that this baby might not do well, so you call them for frequent growth scans. Tell them that take high protein diet, wait and watch. So it's just like being forewarned and being forearmed. That's all. But it's very sad sometimes that we see these pregnancies go to 26 weeks or something and then have IUDs. You cannot terminate a pregnancy just because of that finding, because it
placenta
does not make sense.
sense. Yeah.
So if the baby will not become viable, then that is a natural occurrence that will occur, and then you terminate the pregnancy. That is okay. Advising termination of pregnancy because the placenta is not good is not a acceptable thing. But at least telling them, in many ways, you signpost it for them that things are not going
Not
well
good.
and it might not do well.
This baby had a subchorionic hemorrhage, I think, and then she terminated the pregnancy, and but it did well. The baby actually survived that this thing. But this placentomegaly patient, she was having under surveillance, but the mother developed a subchorionic hematoma, which is expanding. So then they took her for a delivery, and the baby survived, even though it was a preterm, it survived. So placentomegaly, it's basically as you say,
Poorly formed
formed
placenta.
a tissue problem of the placenta per se. There's
Placenta.
nothing other signal. Okay. And somebody has the diabetes was ruled out. So that we had ruled out diabetes
The
before we thought
diabetic
of.
placentas will look different. They will be big. There will be polyhydramnios. The baby will be big. So that is a different type of placentomegaly. This, what Madam is saying, will be more like a homogeneous thing. In fact, many times they think it is a abruption or it is a blood clot. They think like that. That whole appearance, it's jelly-like. When you shake it, you can see the jiggling of the placental tissue there.
Okay. Dr. Preeti, like the sugars were checked, totally normal. Screening, all monitoring was done fine. Dr. Aarti Raghu from Bidar, she has asked, which prenatal screening test for triplets? I think you answered.
Scan, ultrasound based.
Okay. And significance of placental lakes, Dr. Upma Jaiswal.
Up to 10% lakes, 5 to 10% may be there in any placenta, and that is not a problem. When it is more than 10%, it is the same, like I said before, that the placenta is not good, high risk of placental dysfunction. If it is in the lower segment, then you look for other signs of placental adherence, that retroplacental hypoechoic area. And so if it is in a previous cesarean section scar with low-lying placenta and lakes, then it's a very high risk for morbidly adherent placenta. But in a normally placed placenta, usually it just says poorly formed placenta, and just keep a watch for function.
Okay. Thank you, Chinmay. Thank you so much for sparing your precious time and this excellent interaction. And before we are finishing, there's one more question, and that is how to take a decision regarding continuation of aspirin when the scan shows an abruption.
No, if the scan shows abruption, then of course you have to take very drastic decisions. Then you don't continue the abruption. Then you don't continue the echosprin.
Probably the question is for a chronic abruption. A small abruption does not cause any change in the mother or fetus.
So here, there are two things we need to understand. Many people start echosprin when there is growth restriction, or when there is uterine artery high resistance at 22 weeks, 24 weeks. Now, in those cases, there is literature shown to say that it increases the risk of abruption, not because the echosprin increases the risk of abruption, but because those pregnancies are anyway at risk of abruption, because there was the high resistance in the uterine artery earlier. She was high risk of preeclampsia. Starting echosprin after 20 weeks will not help so much. So she will have abruption and it will be a worse outcome because of the echosprin. When you start the echosprin before 12 weeks or 16 weeks, then the risk of preeclampsia becomes low, and therefore the risk of abruption becomes low. If abruption has happened, then it has to be managed like any other obstetric condition. Then you have to stop all the blood thinners and take care of it.
What about heparin when there's a bleed?
Ma'am, you stop everything if there is a bleed.
But they say if it's APLA, you need not stop. That's what.
Then APLA, she has to take care of, like you have to then call the hematologist and do everything. Because once a woman is bleeding, the blood cannot be thinned at that point. So you have to deliver her. Once you deliver her,
these are the small hemorrhages which keep on spotting from first trimester onwards. Second trimester also it continues, and you already proved she's a APLA.
Ma'am, she has to be
always the doubt is there, like would you stop the heparin, continue? That's always a confusion.
There is no message that you can give in a webinar for that. You have to
Yeah.
A senior obstetrician has to talk to a senior hematologist and a senior rheumatologist and take that decision, because that will be
Hematologist always says stop, but we don't want to stop because we are worried that we lose the baby. So many times we are like, what I do is I stop temporarily, wait for the bleeding to subside. Sometimes give tranexamic acid, which works quite well. Injection tranexamic acid given and then convert her to oral tranexamic acid for 2 to 3 days. Put her on high dose progesterones. Many times it stops. I had a mother like that, 38-year-old, 15 years of infertility. I'd lost 2 previous pregnancies because we thought it was cervical incompetence. Third pregnancy, suture put, but every 15 days she'll come with a bleeding episode. So what we used to do, we'll stop the aspirin, we'll stop the heparin, and then give her tranexamic acid and progesterone. She continued, and around 32 weeks, we identified an IUGR. We monitored her. She went up to 35, delivered a good baby, and went home. And that was a miracle because I don't know how they manage a bleeding episode.
So that's a
But,
consultant-led decision with good counseling. There cannot be a generalization for this.
Because we don't know, like, because that heparin we were giving, because actually she was proved to have APLA also. So we had put cervical incompetence also she had. 2 babies she has lost all around 20-24 weeks. And this baby she has conceived spontaneously. Others were all assisted conception. This 38 years when she conceived was a spontaneous conception. And she knew only at 12 weeks. So we had put a Shirotkas for her. And then every 15 days, and she was living with me in the hospital. Every day, hi, bye. We used to meet her every day. So that type of pregnancies can have, that's why the question is there, because many times in IVF pregnancy, I'll tell you, under the table, we put heparin. I accept it because I'm very scared that the placenta may not be good and I don't want her to lose the baby, and I put her on heparin. And when this bleeding happens, then the whole problem starts for us. So that way, I think the questions are all going on that. So I'll just finish with the last question. Early onset IUGR or IUD around 17 to 19 weeks. Is there a need to do a placental HPE? And do we need a genetic analysis of the, I think, the tissue also?
So whenever there is early onset IUGR and you are seeing that there was high resistance in the uterine arteries, there was low PAPE, there was a sign of uteroplacental insufficiency, the placental histopathology will definitely give you a lot of information. Genetic analysis as a workup of stillbirth is always recommended, because even the cause of IUGR in about 3 to 5% cases might be microarray or abnormalities or genetic abnormalities. So in an ideal circumstance, yes. In practical circumstance, because they may not have that much money, they'll have to undergo termination, they'll have to do all this, store the DNA. Store the DNA, do the histopathology of the placenta, do her workup after 6 weeks for APLA and all these things. So if the overriding feature is uteroplacental insufficiency, then if she can afford, let her do the genetic test for completion. Otherwise, explain to her that the cause was uteroplacental insufficiency.
And Dr. Alluri is asked, like, G5A4, only radiological diagnosis of abruptio, patient on icosprin and had a thickened placenta.
Multiple issues. See, again, the detailed history is very important. G5A4 has to be something much more than that. So let's look at the whole picture. It could be an abruption. It could be an APLA patient who has APLA or any other kind of immunological problem. So need more workup than that.
And
the diastolic notch in the left uterine artery, can we start echosprin at 30 weeks? No. The role of echosprin is to improve placentation, and placentation finishes by 20-22 weeks. So there is no role. The second wave of placentation starts at 16 weeks, and therefore the usefulness of echosprin is to start it before 16 weeks. Thereafter, no. And diastolic notch in left uterine artery is not enough, because you need to see the PI of left and right uterine artery and then see the mean uterine artery PI to see if it is high or low. At 30 weeks, the role of uterine artery PI is only to corroborate if there is growth restriction, whether it is uteroplacental. So this uterine artery PI has to be checked before 20 weeks, and then only you can take precautions for IUGR. In the third trimester, the role of uterine artery is only to corroborate with the growth. That's all.
Dr. Vidya has asked the significance of placental calcification in the third trimester.
Ma'am, if it is less than 37 weeks, you're seeing the calcification, you will definitely do the Dopplers, see for any subtle changes in the growth pattern, alert the obstetrician by calling her, but not take a obstetric decision because of the calcification. Again, one of those uncomfortable situations where you cannot close your eyes to it, but you cannot do anything. Once you reach 37 weeks, I think your obstetrician mode has to take over, and you take on that pregnancy thereafter. Don't leave her alone, because there is no method of fetal surveillance that is capable of taking care of everything. So do your CTGs, if possible, offer induction, do whatever, but after 37 weeks, not before 37 weeks.
I think I'll answer Dr. Alluri's question. I think she's worried about that abruption which is shown on an ultrasound. So, madam, like this patient has had 4 spontaneous abortions. I don't know whether it's first trimester or second trimester, but whatever it is, you have to first check out the baby. The genetic analysis of baby is must, whichever fetal products you can get. Then the parental karyotyping. Or as far as the mother is concerned, you have to do an ultrasound to find out like whether she has got a uterine anomaly. These are all basic tests. Then APLA, because we need to know the immunological factor which is there. Then you can think about whether it's abruption, because an abortion, that means it is about before 20 weeks of pregnancy. So there's no point in thinking that an abruption is the one which is causing. It's most probably some other factor which is there, and the placenta has gone for a separation. So as Chinmayi said, this needs a very, very extensive workup, and we cannot just do with an ultrasound to identify what is happening. So the baby has to be checked, and then retrospectively the parents have to be checked, and then you go with simultaneously check out our uterine factor as well as our immunological factor. Is that right, Chinmayi?
Absolutely, ma'am. Absolutely.
Yeah. So I think this is Dr. Jayalakshmi again. Okay, so all that the work without a workup, we cannot assume it's cervical incompetence, or we cannot assume it's repeated abruption. If the placenta is not good, it's going to abrupt. We don't know, but where the placental problem started. Was it from the fetal level or at the maternal level? So you need to evaluate thoroughly before you can come to an idea like why it's happening. I think we have covered everything. The questions are all covered. Thank you, Chinmayi. Thank you so much.
I just thank all the audience for actually staying back for so long and answering.
So that's why we keep it like we want one single speaker and we want to totally exhaust them before they go. That's why.
Thank you for the opportunity. Thank you so much.
Thank you.
It was
Thank
a
you
pleasure.
so much.
Thank you. Thank you.
Manjula will give the formal vote of thanks, please.
I thank the speaker, Dr. Chinmayra, for giving such a wonderful insight about the challenges we face in the ART pregnancies. And I thank Dr. Chamila, and I thank all the esteemed audience who participated in this webinar, and otherwise
Shield Pharma.
Shield Pharma
And
for
and
all the
special thanks to Sahiti for staying back for us. Thank you so much, Sahiti.
Thank you, ma'am.
Thank you.
Thank you, ma'am. Thank you, Manjula. Thank you, everyone, for participating.
Thank you. Bye. Thanks.
Bye.